More and more.
Gone quiet. Is that the nod to start? Yeah. Okay. So, welcome everybody here in the room and online. Thank you very much for joining us this evening. These inaugural lectures are an opportunity for us to celebrate our new professors, and I'm really delighted that we've got Professor Eve Worrall that's going to be delivering the lecture this evening. Before I do a brief introduction, just a few housekeeping notes for people in the room. No fire alarms planned, so follow the people at the back if there is a fire alarm, and they'll direct you out the building. And the toilets are on the right, just past the kitchen as well. But I wanted just to start with a few words of introduction, because I've known Eve for over 20 years now in a number of different capacities, and in each phase I've learned a great deal from working with her. When I first joined LSTM, Eve was just completing her PhD with Madeline Thompson in the infamous Mousat office, which was instigator of some of the best social events at LSTM back in the day. But then our paths crossed again several years later when she rejoined LSTM as part of of LAF, which was the consultancy arm of LSTM at the time. And we did a little bit of work together then, and she taught me a lot about spreadsheets, milestones, deliverables, profit margins, etc. But I think most importantly at that time, she introduced me to the brilliant Sisters Against Malaria, or SAM network, which resulted in many a fun evening at conferences and meetings around the world. And I think we've both benefited from that incredible network of amazing women and developed friendships that's still going today from that network that Eve and others, Jenny and others, were founders, members of. We later worked together on several international consortia, where she was a remarkably effective programme manager, laser focused on impact and value for money, but always championing the work of others, quick to spot risks and opportunities as well. And so for more than a decade, we worked together on projects funded by the EU, Welcome and UKRI. And I think that we made a pretty good team working together. I think Eve bringing her formidable spreadsheet skills, her incredible work ethic, and her expertise on policy and health economics to these very multidisciplinary projects. But also, crucially, I think, an ability to seize the opportunity to have fun. And she often nudged me out of my comfort zone, and I remain deeply grateful for that. And I do look back on these times and these projects with great fondness and also a lot of pride for what we did together. So Eve then took her career in a different direction to focus more on her passion for economic health economic evaluations, and set about moving from a programme manager track to an academic career pathway. And this wasn't an easy thing to do, not due to any gaps in Eve's capabilities, but because the system at the time wasn't really structured to enable this type of move. But anyone that knows Eve knows that she's nothing if not determined, and not only did she succeed, but she ensured that she put in measures to ensure that where she trod the path, others could more easily follow. There's so much more I could say about Eve's achievements, but I'm sure we're going to hear some more about those directly from her during this lecture. So for now, it gives me enormous pride and great pleasure to introduce Professor Eve Worrall, a colleague, collaborator, occasional co-conspirator, and above all, a very good friend to deliver this evening's lecture.
Wow, thank you, Hilary. Professor Hilary Ranson, CBE, get that one in there. Super proud. So, yes, thank you so much for coming in person, online, and thank you also to the people who catch up later. because actually that's how I normally listen to the inaugural lectures. This is the first one I've been to in person live, so I'm excited to be here. So I've spoken to a few people about this, and actually lots of people say this is a really tough lecture to give. It's probably the one that requires the most thought. It's supposed to be accessible, beyond the discipline, beyond academia, and that's not the usual style of talk that we give. But then I kind of reflected on it a bit more, and I thought, well, actually, some of the most uninspiring talks I've been to have been overly technical, long-winded, full of jargon, and just left me totally confused. So what I'm going to aim to do today is really tell you the story of how I ended up doing this job, which Hillary's given you the kind of high-level picture on, and then really reflect on what I've learned and what I think is worth passing on from what I've learned so far. So, the question, what's economics got to do with it, is inspired by what we always ask at the beginning of our health economics lectures, which is, what do you think health economics is about? And most of the people's first guess is to say, oh, it's about money, which it's not really. Economics is the science of making choices under constraints, and what economists call those constraints really is encapsulated by the term scarcity. And so it becomes immediately apparent that health economics, and especially global health economics, has a lot to do with it. Health economics, the primary aim of health economics in public health is to maximize the health gain for the available resources. And clearly, because choices occur at every level within the health system and take place against a backdrop of extremely limited resources, sometimes more limited than others, then health economics is clearly really relevant. And of course, some people will have already noted that the title is inspired by a Tina Turner song. Now, if you know who Tina Turner is, I don't need to say anything, but if you don't, I strongly recommend you look her up, because she's an absolute legend. So, I used to think that my journey in global health economics started with my economics degree here in Liverpool in the 1990s. It was great. I loved macroeconomics and the way that it explained through theories and empirical work how economies work and how the impact of government decisions affect our daily lives in terms of inflation, interest rates, employment, how the economy is expanding or contracting. And that made total sense to me. Rates of change, mathematics, government decisions, I could see the impact of it all in the shops around me, in daily lives, as well as on the news. I also took the health economics modules, which again made total sense and helped explain how the market for health or healthcare is really different to the market for the other things we need, and how this difference made it interesting and somewhat special. The issue was that all of my course mates were heading off to work for the Bank of England or HSBC or to the big accounting firms. And I knew that this wasn't really for me, but I didn't know what I wanted to do. I didn't know really what I could do. I had no idea that being a health economist was a real thing or a job. So luckily for me, on graduation day, I was chatting to my macroeconomics lecturer, David Peel, Professor Peel. In fact, asking him about job opportunities. And he mentioned something in health economics, and he suggested that I go to the student notice board. So I went upstairs in the Eleanor Rathbone building over on the other side of campus, and there was a tiny postcard with some information on it about a PhD opportunity at the Liverpool School of Tropical Medicine, looking at the economics of malaria early warning systems in Africa. It mentioned a number of southern African countries, and then there was a stream of random letters, which turns out was a website address, the first website address that I'd ever seen. So luckily for me, I had a friend who was a school friend who was working at Department for Work and Pensions in my hometown, and he had access to the internet. So I phoned him from a phone box, read out these letters. Anyway, after a few attempts, he finally found the details, and I applied. Must have been interviewed or applied, don't remember, that's all a bit hazy. But I ended up, sorry, that's scrolled down. So I ended up with this PhD opportunity. So I remember starting my PhD, walking up the stairs in the old school building, seeing that weird window that's still there today and always makes me think back to those early days of my PhD. Oh, wrong button. No? It's not moving. There we go. So it's 1997. I'm suddenly in this new institution focused on an array of infectious diseases, most of which I've never heard of. The erstwhile Department for International Development of the British government had funded the Liverpool and London schools of tropical medicine to deliver malaria knowledge programmes. And it seemed like there was a lot of flexibility for the schools to take this in whatever direction they saw fit. The group I was part of was MALSAT. As Hillary's already said, we did organise good fun nights out as well. But it was a canny amalgam of the words malaria and satellite, and it was led by Dr. Madeline Thompson, who also supervised my PhD. Madeline is a wonderful, warm, wise person, but she's also a visionary. The MALSAT work was hugely ahead of its time. Madeline was pioneering the use of weather, climate, and satellite data to predict outbreaks of malaria and meningitis across Africa. She was also working in true partnership with Ministries of Health and the meteorological services across Africa, and we regularly had colleagues from Ethiopia, including Dr. Tedros, the current director of the World Health Organization, from Namibia, from Kenya, from Zimbabwe, visiting our group to work on data analysis and publications with the team. So the exact story behind how my PhD came about was, I think, told to me by Madeline years later. Apparently, the Department for International Development had done a review of the malaria knowledge programmes and noted that there should be some economics in it. In fact, this is normal for all UK government programmes. They all have to define an investment case for what they're doing before they should be funded. And the UK Treasury actually have a guide on how to do this called the Green Book, which is essentially a manual on how to do economic evaluations or cost-benefit analysis. And it's used across all government policy areas. It's actually a really great resource, and if you're interested, highly recommend it. Anyway, so off the back of this funder request to include economic analysis, the PhD opportunity came about. So the brief was really broad. I had to basically do a PhD on the economics of malaria early warning systems. For a recent economics graduate, that might have been a bit bewildering. But as I already noted, I firmly believed that economics can explain uncertainty and complexity. I'd been exposed to differential equations and macroeconomic models, and I understood the fundamental principles of health economic evaluation. And it turns out that modelling disease and modelling economics has a fair amount in common. But what I didn't understand was malaria, early warning systems, African health systems, how to do a PhD, etc. So looking back, I think the scope to be creative and have quite a blank slate was really attractive to me. I probably would have been a lot less interested if there'd been a work plan that needed to be delivered. Madeline gave me lots of creative freedom to learn and explore. The LSTM library and the work of colleagues around me was also a great source of knowledge. So in those days, you had to go down to the library to find and read a paper. So I learnt a lot by just browsing journals, hand-searching references, and reading and reading. Of course, by simply being around the scientists and malaria experts from the UK and Africa, that also taught me a huge amount. So at the time, MALSAT was collaborating with a Kenyan colleague, Dr. David Sang. Malaria epidemics were a major public health problem in the highlands of Kenya, associated with higher temperatures and seasonal rainfall, and corresponding to key points in the tea production cycle, and putting workers' lives at risk when outbreaks occurred. So we conceived a study to calculate how how malaria epidemics had an economic cost through looking at the morbidity and mortality among the Kenyan tea estates. In addition, we'd be able to calculate how the productivity of tea estates were affected. Many tea pickers were paid by the weight of their tea. So the impact of malaria on reduced or lost productivity would be really easy to measure. Since malaria in this area was also closely correlated with weather, it was also predictable with malaria early warning systems linked to climate and weather forecast data, and therefore potentially preventable. So our hypothesis was that lost lives, health impact, and reduced productivity would create an investment case for both malaria early warning systems and the malaria control interventions that these could trigger. So I spent months developing survey tools and data collection frameworks to gather the impact on workers and their families and the tea estates. Unfortunately, I never got to go to Kenya to do this work. I'm not sure why. Maybe they'd heard about the Malsat party. But I learned a huge amount about the methods for collecting cost data. So this time and effort were not wasted. In fact, the foundational learning that I did then informs a lot of the work that we do today. So it was disheartening not to get to go to Kenya. But luckily, through Malsat connections across epidemic-prone Southern Africa, an opportunity arose to go and work in Zimbabwe at the Ministry of Health and Child Welfare in the Vector Control Department of the National Malaria Control Programme. And it's here that I started to learn a lot about the nuts and bolts of planning, financing, logistics, and how that came together with technical expertise to deliver public health interventions on the ground. It's really important to acknowledge that at this time, financing for malaria control was almost exclusively from domestic sources, including primarily governments and to a lesser extent NGOs, civil society and the private sector. Now, the Zimbabwean Ministry of Health had a long-established annual programme to deliver indoor residual spraying, or IRS. IRS involves spraying the walls of people's houses with insecticides, and the government did this annually for tens of thousands of people. So my aim was to work with colleagues in the malaria programme to evaluate the cost of the IRS programme, and then later on to use this to explore how the cost and cost effectiveness of the programme could be optimised using the malaria early warning systems to target IRS in space and in time and make it more cost effective. Again, the idea being that this would demonstrate the economic value of malaria early warning systems. Now, I actually did do this, and it's published if anyone wants to read it. But to do this, I needed data, not just any data on health, but really data on how much money was allocated to malaria control, how much was spent, and what it was spent on. The majority of the financial information I needed was in the office at the end of the corridor to where I was sitting in the Ministry of Health. Now, I was sharing an office at that time with a colleague called Mr. Ziva. I have a photo of me and him somewhere, but I can't find it, unfortunately. So he was the head of the Malaria Vector Control Programme. Anyway, so I set off down the corridor to the finance office to ask for this information. It's kind of obvious to me now what was going to happen when I requested that information. I was met with a polite but firm refusal. I can't remember how I felt about it at the time, but I'd like to think that I realised pretty quickly that I was going to have to prove myself, build trust and relationships before anything would be forthcoming, and rightly so. Now, at that time, Mr. Ziva had recently received a new PC equipped with Excel software. But he hadn't been trained in how to use it. He also needed to count a pile of money and put it into envelopes for the districts for all the staff who would need to be paid for the IRS programme. The trucks were literally lined up outside the Ministry of Health building in Harare, ready to take the insecticides equipment and the money up to the north of the country to launch the spray programme. So Philip Ziva and I got to work making a spreadsheet to calculate all the payments, counting the money and sealing the envelopes. And that day I was able to do something really useful and had contributed directly to the work being done, and I started to become a part of that team. So the next time I went up that corridor, Philip came with me, and guess what? We got the information that I needed. And that's how I learned many crucial lessons that I still apply today in the work that we do. We don't have a right to access data, knowledge, or expertise. That right has to be earned and granted. Our objectives as researchers are unlikely to be aligned with what the people delivering health services need, in the short term at least. And so we have to make sure that what we contribute is something useful. I think looking back, that's probably the first time that I started to understand what partnership means in global health. I think at that time, I probably thought my contribution was going to be technical. I was a health economist. I had methods, I had spreadsheets, I had analytical tools. But what I learned was that none of those things really matter until you've got trust and partnership. And that lesson has really stayed with me. Even now, for example, some work that we're doing in Benin and Kenya, we need information again on budgets for health programs, but we've deliberately postponed the meetings with the NMCP directors to make sure that we can do some interim analysis, package it up with a policy brief, and frame it so that it's directly relevant to their funding application that they're making to the Global Fund, so that when we go and ask them for something, we give them something first. So, I'd already mentioned that in the late 1990s, financing for malaria control in Zimbabwe was funded predominantly from domestic sources. And the picture was similar across sub-Saharan Africa, as shown in this chart. Government spending is the blue bars, out-of-pocket spending by patients and families is the orange bars, private health insurance is the purple bars, and the small green cap on the top represents development assistance for health across all health areas. In other words, the contribution that wealthier countries such as the UK and the USA make to African health spending. You can see that between 1995 and 1999, total health spending was growing very slowly year on year, with development assistance responsible for around 2 to 3% of the total. But something really exciting was on the brink of happening. It really was the beginning of a revolution in global health financing and external investment in infectious diseases and maternal and child health. The year 2000 was a pivotal year in global health, with several key events in policy, financing, and aid architecture. In the year 2000, the UN launched the Millennium Development Goals. The Bill and Melinda Gates Foundation was established. Gavi, the Vaccine Alliance, was launched at Davos. And then in 2002, the Global Fund to Fight AIDS, TB, and Malaria was launched off the back of conversations that Kofi Annan had initiated in that year 2000 Davos summit. This had a dramatic effect in sub-Saharan Africa. Total health spending in the year 2000 was 11 percentage points higher than it was in 1995. But health spending in 2005 was a whopping 34.6 percentage points higher than it was in 2000, with a further 33% increase between 2005 and 2010. This increase is demonstrated even more dramatically when we look at development assistance financing for malaria across the 10 so-called malaria-eliminating countries from a 2017 paper. It went from literally zero to around $200 million in the space of a decade. So at that time, between 2001 and 2004, I was doing my postdoc in the economics of malaria at the London School of Hygiene and Tropical Medicine, working under the formidable professors Anne Mills and Cara Hansen. This was a really brilliant experience. I was surrounded by other health economists working on similar issues, and again, learning so much through simply being around and able to absorb all this knowledge. Although the funds for malaria control were increasing, the policy at the time was still focused on targeting pregnant women and children under 5. And the tools we had were limited. The technology to incorporate long-lasting insecticides onto bed nets had not yet been developed, and so regular retreatment was required to make sure that the nets remained effective at killing mosquitoes and preventing malaria. So the work we did focused primarily on identifying and evaluating strategies to target malaria control interventions with an equity framing, but also in trying to leverage the private sector as a distribution channel and a way to enable those who could afford to purchase insecticide-treated bed nets themselves. And it's that work that took me to Tanzania. Working with colleagues from the Ifakara Research Centre, we travelled across Tanzania visiting markets and shops to survey the price and availability of bed nets and insecticides. Those were incredibly happy hours on the road in what still feels to me like the most beautiful country in Africa. We were incredibly happy. We listened to a lot of Desmond Dekker and we laughed a lot. We ate bad food, we slept in very basic accommodation, and we enjoyed such exciting nights out as going to look at this bridge. We also went to places where a young white woman had never been seen. I made a lot of babies cry with my arm hair, weird eye and skin colour, and I had my eyes open to the realities of how people really lived away from the cities. My good friend and co-researcher Ellie Akeem shared in the fun. He knew exactly what I'd be interested in markets, weird stuff and kitsch. He expertly built trust and relationships with shopkeepers and communities so we could conduct the work. That time taught me about fieldwork, teamwork, and to respect the hard work and commitment that goes into collecting every variable on every survey tool that we develop from our comfortable offices. It's also the source of my only major regret is that I didn't learn to speak Kiswahili properly. I should have done. Enough said. Being at the London School also brought huge unearned privileges. Simply by being in London at a renowned institution with close geographical and institutional links to the UK government department and Geneva-based organisations yielded opportunities that would not be available to people outside of London and to a lesser extent outside of the UK. I don't know if I was aware of this at the time, and it wasn't really ever questioned or discussed, but I do want to acknowledge this now. So, in spite of loving my time at London School, I had an urge to try the world outside of academia. I left London School to take up a post at an organisation called New Philanthropy Capital, founded by a dozen wealthy men who'd made a lot of money in the British finance boom of the 1990s. The idea was to provide investment banking style guidance to philanthropists looking to maximise the social return on their investments. Now, this made total sense from a technical economics point of view, and it's essentially the aim of cost effectiveness analysis in health economics. Most of NPC's work was in the UK, and I didn't really fit in with the people there, but I did get to meet George Michael's sister, Yoda Pianiotu. Now, I grew up in the 1980s, and George Michael, I mean, just what a guy, a really, really lovely man. If you don't know him, look him up too, and Desmond Dekker. So Yoda ran George Michael's Foundation, which was a really great organisation with a giving policy that was really ahead of its time, supporting LGBTQ plus young people before that was really mainstream. She was, and probably still is, a lovely, intuitive and smart woman. We had a really extended meeting, which turned into a chat. And by the end of it, she said to me, "You'll be back in Africa within a year." She wasn't wrong. So one day, out of the blue, at my desk at NPC, I got a call from Liverpool Associates in Tropical Health, which, as Hilary said at the time, was the for-profit consulting arm of LSTM. I'd had a job interview with them just before I left LSTM at the end of my PhD. I didn't get the job, but apparently I gave a good interview, and when they wanted to hire a health economist, they reached out to me directly to gauge my interest. Remember, I said nothing's ever wasted. So quietly whispering in the NPC office and trying to play it cool, we arranged an interview. And that began my 6-year time as a global health consultant. This was such a broad and interesting role where I learned about budgeting, contracting, recruiting and managing teams to deliver projects and consultancy work in a range of locations and on different topics. I also delivered my own portfolio of consultancy work, and the network of people that I'd met during my time at LSTM and London School was incredibly valuable in gaining opportunities and access to expertise. And LATH had its own network of clients. We bid on large technical assistance contracts to deliver health systems, health financing and disease-specific interventions across low and middle-income countries. including for the African, British and US governments and agencies such as the World Bank. So it was a great way for me to learn and be exposed to how overseas development assistance works, or sometimes doesn't work. There were so many memorable projects in this role, but to mention just a few. Firstly, the consultancy that I was sent to after the financing consultant that we'd hired left halfway through in Mozambique, in Portuguese. Perfect, when you don't speak the language. But it turns out that building a financing model for a health sector strategic plan is actually the same in any language. And yes, I did it in Excel. But the best thing about this consultancy was that it's where I met, and shortly after we hired another fantastic health economist. It turned out to be the first of 3 times when we would hire this person, and they're a highly valued part of our team today. Another important project for me was in Uganda, working for AMREF to articulate the value of community health workers. I remember meeting a community health worker who told me why she did the work as a grandmother caring for her community and wanting to give back what she could, and how much it cost her both in time and money to buy wood, matches and other items to boil water to tend to sick children. This really shaped my effort in health economic evaluations to identify and highlight those and other unpaid contributions or voluntary contributions. However small their value might be in terms of the total cost of the programme, they're a crucial contribution which deserves to be properly recognised and documented. Without it, health systems would be weaker and community health would suffer. So the final piece was a series of consultancies delivered to Gavi, the Vaccine Alliance. Immunisation was totally new to me, but I had a decent understanding of the Geneva-based partnerships, global health partnerships, from working with the Rollback Malaria Initiative previously. I did a series of consultancies for Gavi on their monitoring evaluation framework, on their annual work plans, and then ultimately their 5-year strategy. Facilitating those calls with a range of Gavi stakeholders and turning it into a coherent strategy was incredibly valuable in helping me to understand the drivers between global level policy and financing decisions. It informs how I think about global policy engagement today and complemented the country policy experience that I gained during work with the Ministries of Health in Zimbabwe, Tanzania, Mozambique, and other partner countries. So it's worth a little segue into policy here. Health economics, health policy, and evidence is so interlinked in global health that we expect every health economics publication and PhD to start with the policy question and end with the policy implications. Any of my PhD students listening, take note. It's certainly been my experience that when anybody makes a policy decision, at whatever level, they're normally thinking about the resource implications of their choice, which, as I mentioned earlier, is exactly what economics is for and about. However, the way we apply economics and the tools that we use is different at every policy stage. Now, as close colleagues will know, I love a simple figure to explain something complex. And this one provides a perfect basis for thinking through the right economic questions to inform each stage or iteration of the policy process. So at the agenda setting stage, health economics is useful for providing evidence on the impact of a problem. It's where the use of burden of disease estimates in cases, deaths, and disability-adjusted life years comes into play. But it's also where we aim to quantify things in monetary terms, for example, by estimating the direct healthcare expenditure to governments and households, as well as opportunity costs such as work time or productivity lost, like the tea estates in Kenya. At the policy formulation stage, we are looking at options to address the issue that's made it onto the agenda, like global health did in the 1990s. Here is where economics, other social sciences, and public health science comes into play to propose options to tackle the problem. From an economic standpoint, quantifying the burden is not enough. We have to be able to show that we can actually do something about it. For me, that's why being in a school of public health alongside clinicians, scientists, entomologists, and health systems experts is key. Without the interventions that they develop, we're describing a problem, but we don't have the strategies to address it. Policy selection. This is where health economic evaluations come in. Cost effectiveness analysis and cost benefit analysis, where we're systematically comparing the options based on both their impact and their cost. And it's where collaboration is key. If we only look at cost or we only look at impact, we won't make smart choices. And if we forget about acceptability and feasibility across all key actors and stakeholders, we won't make impactful choices. So you need a variety of skills and expertise. Then comes the fun bit, actually doing it, which of course is not the preserve of academics, but we're often lucky enough to get the opportunity to work alongside colleagues in our partner countries to support ministries of health and increasingly education to do this. Here's where we begin to learn if the choices we made were smart or impactful, if we budgeted properly, and if the finances were in the right place at the right time to make things happen. And then, through programme evaluation, we can come back and redo our cost effectiveness analyses to see if we really achieved what we thought was possible and explore what things we could change to make and improve the value of our policies on public health. That brings me on to my first opportunity to conceptualise and supervise a PhD, which arose when I took the position to be manager of AVECnet with Hilary. AVEC was a really wonderful experience. We had a large and, in fact, growing budget because it was funded in euros and the pound was falling against the euros. So every year our budget went up and up. Anyway, we also had a fantastic array of complementary work packages, brilliant scientists and collaborators from Kenya, Tanzania, Malawi, Ivory Coast, Burkina Faso, Italy, France, Greece, Switzerland, and the UK. This was also my first time working with colleagues from Francophone West Africa, an incredible opportunity to expand my links, professional collaborations, and friendships across the continent of Africa. And those of you who know or have worked with Hilary are aware, she's such a clear-sighted, brilliant strategic leader, and AVECnet really, really benefited from that. Many of the early career African scientists involved are now highly successful world-leading scientists. The legacy of that project is immense and still growing, and I am also really proud to have been a part of it. I learned at close hand about a leadership style that listens, supports, and enables, and develop skills in governance and management of large and complex research consortia. And honestly, I did have some of the best fun developing Excel spreadsheets to my heart's content. But Hilary said to me early on that I'd get bored in that role, and she encouraged me to do more. And that's when we devised a PhD on vector control policy with Kemi Tesfagzi, who's now with the Gates Foundation. And it's also when I probably started to have that germ in my head planted, probably by Hilary, about a return to academia. So, as Hilary said, together with colleagues from Burkina Faso, Malawi, and Kenya, we went on to work together in other major research project consortia with additional partners from Cameroon and another generation of fantastic early career scientists from the continent. My role morphed into a more research-intensive role, and I started to take on more research projects and produce more publication outputs. Another person who supported me on this journey from the start, actually, is Professor Jenny Hill. She gave me my first consultancy project in 1998, supported me to prepare for that job interview with the London School in 2001, and more recently invited me into her StopMIT project with Hafitz over there, and the Integration Consortium with a new set of collaborators from Indonesia, Mali, Burkina Faso, Italy, and France. It was a long journey from around 2017 to 2020 when I finally gained entry into the LSTM career track scheme, and to 2022 when I popped out the other side, a fully fledged academic. Career track shaped my understanding of how to work in a way that the academic system values, which of course is income from research grants, outputs, and education. But at LSTM, it also includes citizenship, impact, mentoring. This paved the way with another chunk of hard work for promotion to reader and finally to professor last year. but it didn't shape who I am, what I value, how I work, or what I do. That has come from the opportunities, experiences, collaborations, and partnerships that have taught me how to use my skills in a small way to contribute to improving global health. So I asked ChatGPT to identify the values that run through my story, and it came up with trust, partnership, humility, capacity strengthening, continued learning, real-world impact, and practical. I have to agree that along with authenticity, laughter, and music, and Excel, I am pretty fond of all those things. So you might have noticed that at the start of my lecture, I said that I used to think my journey in global health started with my economics degree. I recently had a big birthday, and my friends and family pulled together a photo album. Now, there's one picture that my sister Maya put on there, which I don't remember actually having seen before. And I think that tells the real story of where my journey started. Barefoot, nappyless, in the back garden in Kitwe in Zambia, with our next door neighbours Yvonne, Lorraine, and my sister Maya, who will almost certainly also remember the name of that dog. So what have I learned since those days in Kitwe? Obviously, relationships matter more than data. We still need the data. And when I started out, I probably thought that data and evidence changes policy, and it does. Without relationships and trust, the evidence simply won't be taken on board. I've learned to try and be useful before or even instead of asking for what you want. This one doesn't take much interpretation, but sometimes I need reminding of how important that is. No effort is wasted. There's been so many examples of where something didn't pay off immediately, or I felt like it had been pointless, but sometimes years later, it comes back to you and you realise that there was value in the effort after all. I feel like actually this is something that happens to me quite a lot. Learn from people who know different things. This is such an important one for me, especially as you advance in your career. It's quite hard to get feedback. People think, oh, you've made it, you don't need the guidance. But I'm always up for a recommendation or advice, particularly from people who see me differently as to how I see myself. The small comments from people that give you a glimpse of how they see you can be pivotal in shaping how you see yourself. Sometimes it's tough to hear, but I know when I've been brave enough to really listen, it's definitely helped me. Respect the field workers' time and effort, and always acknowledge the volunteers and community member input, which goes hand in hand with being mindful of your own privilege. Economics gave me the tools to evaluate choices, but through people, project, and places, I've learned why and how these choices and trade-offs matter. So looking forwards, I want to finish with what our next steps are. These are really difficult times in global health. Those heady days of growing budgets and new global health partnerships are behind us for now at least. And even the focus on evidence-based policymaking is under threat. The climate crisis, epidemics, and the threat of pandemics feels existential. The imperative to show the value and importance of investing in public health feels stronger than ever, and the choices between what can and cannot be done with available resources feels even more stark. Yet some things are better. Health economics is recognised as a key part of informing policies and decision-making in global health. The Africa CDC has set strengthening health economics on the continent as a key strategic priority. The expectation of equitable partnerships in global health research is mainstream. Collaborative, multi- and interdisciplinary research is common practice, as is community and stakeholder engagement. All these things provide hope that policy choices and investment decisions will be smart and impactful. Some of you may be aware that last year we established a Global Health Economics and Financing Unit at LSTM. And this is what I'm focused on building now for the future. It brings together everything I and other colleagues have learned over the past decades into a mission-driven unit at the heart of which is a global network of people with a broad range of contextual knowledge and expertise. Not all the people you see on this slide work at LSTM. And that's the point. This is a dynamic network of colleagues with similar goals and aspirations who can be mobilised to work together to apply health economics across a range of global health areas at different policy stages, sharing knowledge across Europe, Africa and Asia. So over the past 3 decades, I've learned that economics has a lot to do with people. It's about understanding the decisions and choices we make when resources are limited, whose voices are heard, whose needs are prioritised, and who can use evidence to make better decisions. In global health, those choices matter enormously. They shape who receives services, who remains vulnerable, and ultimately who gets the opportunity to thrive. And that's why economics has got everything to do with it.
So much, Eve, for really just such a perfectly structured talk that brought together the personal journey that you've taken, but also I think taught us a lot about that interface between economics and policy and why that matters so much. So really, thank you so much for that. We do have some time for questions. If there are any in the room, we'll take those first. Yeah.
Hello, great talk. Could you translate the tea harvester incapacitation into kind of like food harvesting? And I really want to understand the secondary famines in Brazil and Egypt in the 30s and 40s when everyone got malaria at the same time.
Okay.
I can't find agricultural worker incapacitation data, but it sounds like you might have some.
Have you looked at those old studies on the macroeconomic impact of the malaria elimination in the Americas? There are some papers on it. I know of them, but I can't recall them off the top of my head. But there is some evidence on that. If you drop me an email, I can share what I am aware of. But yes, it will probably be done from what I know. And in fact, my colleague Katie on that slide, I will show you her picture. Where is she? Katie knows quite a lot about this because we've just tried to do a cost-benefit analysis where we use macroeconomic models to look at the impact of investing in malaria prevention in school-age children and show how that increases their intellectual capabilities and later their earning capacity. So we looked quite a lot at that literature trying to link economic outcomes. There's definitely something there, I think.
Excellent, thank you.
Any other questions? Yeah.
Thanks for the talk, Eve. Really brilliant. I'm a bit heartbroken to not see any snakes anywhere in your slides. Especially because I was in Kitwe recently to look for trial sites as well.
Really?
So that's a full circle moment there. So my question is about your career trajectory. How did you reconcile strategic planning, some plans falling through, and serendipity? So being in the right place at the right time. And would you have any advice for a young health economist as yourself starting in this day and age on how they can structure their career?
I don't think I had a plan. I mean, in all honesty, I didn't have a plan. I guess that's the kind of the point. I think probably, I mean, I worked hard and I've always given everything to what I've done, but that wasn't a plan. I think having good people around me who supported me, being in the right place, and I guess that's a nicely framed question that I can use to promote our unit, because I think being a health economist is quite lonely. There's only ever one or two of us, unless you're very lucky to be in a group with lots of people. And so one of the aims of our unit is to really connect people. And, you know, I'd like to think, and somebody said this to me, you've got tentacles everywhere. And actually that's the point, is that I'd like you to come and say, okay, actually we're going to do this, we're going to do the Any Snakes trial in Zambia, can you find us a health economist? And so through the unit, we want to be able to really find those individuals, link them up with the capacity strengthening, with the partnership, just with another friend on the end of an email who's done something, who can share a tool. And so I guess that would be my advice really, is to network. And I think the other thing that I benefited from, obviously, as you can see, I haven't had that linear trajectory. And I think that's really benefited me, because it would have been really difficult probably to get that access to the high level policy discussions in Geneva or at national level had I not worked as a consultant. I just had to get in there and do it. So I would say if you want to succeed in academia as a health economist, I don't think necessarily just staying in academia is the only way to go about it. I don't know if I answered the question.
You did. Thanks.
Any other questions in the room? Or I don't know if anyone's looking online. Oh, Justin. Yeah.
Maybe a big reflective question, and I'm focusing in on the word, the theme of choice, and health economics being a tool to inform choices. I guess we're living in a current environment where choices are not always being made based on good evidence. What's your sense of that environment? Do you think, has it always been the case? Do you see health economics as becoming less relevant or more important because of this sort of that sort of context?
Or you always ask the tricky questions, Justin, don't you? I guess where I struggle is that even when we're talking about the intersection between health economic evidence and political economy, that can be modelled and explained with frameworks and data and rationale. I think where things get really tricky is where there appears to be no rationale behind the decisions, because one of the other fundamental premises of economics is that actors are rational. And so when actors are no longer rational, it's tricky. So I do think it is tricky times. I think we've been through tricky times in the past, but this one feels pretty bad. So I think that's where, we're back to that agenda setting stage. We're back to having to advocate for the importance of global health, for the importance of equity, for the importance of investing in supporting people who are not our next door neighbour or are not our, race or ethnicity. And so I think everything is cyclical, and we've just got to go back to maybe where we were in the late 80s, in the doldrums, where there wasn't that investment, and start advocating again.
Time for probably one more, if there's one more question.
There's some online.
Oh, someone online does it, okay.
If you want to do it in the room first.
Let's take one in the room and then, yeah.
Eve, thank you very much for this presentation. I'm happy to see the journey that you have gone through to be able to establish the link between economics and economics. I'm interested in that process, and I've learned a lot from. My question is, not really a question, but it's just a worry. I come from an environment where the mosquitoes so much that we did a study, and I asked one medical doctor, why is it that the mosquitoes are more common in Africa and they cannot be eradicated? He talked of reinfection, the environment. So my concern is, with this result, with the partners that have pumped a lot in Africa, trying to reduce malaria or to eradicate malaria, the cases, because the environment is not friendly in terms of the cleanliness, in terms of in terms of the drainage, these infections keeps on repeating, and with the dwindling global resources, with COVID and the policies from US, and the fact that this malaria has not been controlled, I'm just worried on how Africans are moving.
Yeah.
Because how the problem keeps on, just like schistosomiasis.
Yeah. You're right, Damien, and
It's worrisome.
Nigeria in particular is one of the countries where even at the good times where there was lots of investment, malaria was really, really challenging to tackle. And it's just the force of infection there is so, so high. And so with the dwindling resources, we're all concerned. And I think it comes back to what Justin was saying really about, you know, how do we deal with that environment? And so I think we've just got to keep advocating and reminding everybody that this is important and we can do something about it.
Exactly. Thank you.
Okay. Natia wants to first say that she's very proud to be a mentee of Eve, and this is a wonderful lecture and timely as well for her. So, and the Toka is asking if you could talk about the challenges you've encountered working in global health, coming from your social and behavioral science background.
Okay, challenges coming from a social and behavioural science. Well, yes, I mean, I think it's got a lot better. But there was a time where it was very rare to not have just a room full of clinicians from the UK making decisions about global health policy. I think that's come on in leaps and bounds, but it always was quite tricky. There is still a power imbalance between the North and the South and within disciplines and expertise, but it has improved. I think one of the key things is that speaking different languages, and I mean technical languages, is always the first hurdle to overcome. So always checking, well, when you say that, what do you mean? When you say model, do you mean a mathematical transmission model or do you mean a kind of a social behavioural framework model? So always checking what people actually mean when they're coming from a different background and making sure that you explicitly learn to build those shared languages. And as I say, I regret not learning to speak Kiswahili or French, but I think I've learned to speak clinicians, clinical trials, epidemiologists, entomologists. I've learned all of those lingua francas. And I do get impatient, people will know. I do get impatient when I'm expected to know all of those technical terms, but then when I say cost effectiveness ratio, people go, what? So I do still think, you know, there is a little bit of information asymmetry there and a bit of expectation that we should learn to speak a different language, but other people don't have to. But I am aware that I live in a very, very thin glass house there because of my English.
That's all I have. Yeah.
Okay, thank you very much. Thank you, Eve, again for really great talk, and also for all your contributions. You touched on just a few of those today, but as you were talking, I was just thinking, I wonder if you're going to mention this or that, and all the many different things that you have achieved throughout your career so far. And I'm really excited about the next phase of it. Just wanted to say that this lecture is part of a series of inaugural lectures where we welcome our new professors to LSTM, and I believe the next one is on the 8th of July, and it will be Professor Kondwani Jambo, who will be talking accidental scientist, immunologist by choice. So please do try and join us for that one. And we have refreshments outside, so please do stick around to chat to Eve and to colleagues, and thank you once again.